Greetings and good evening from Black Health Matters. My name is Lynette Roach, and I am the Media Relations Director of BHM. This program is made possible by our sponsor, Eli Lilly and Company. I'd like to extend a warm welcome and thank you to our community partners, the Port City chapter of the Links Incorporated, the Texas Springs Cypress chapter of the Links Incorporated, the Associates of the North Houston Suburban chapter of Jack and Jill of America Incorporated, For the Breast of Us, and Dr. Stacey Jones-Reed of the Family Health and Wellness Practice. We are nearing the end of Minority Health Month, and tonight you will be inspired by the testimonials of breast cancer survivors who are thriving and a breast surgical oncologist who is doing the work in our community. But before I introduce them here, let's cover some housekeeping items. Please share your questions in the Q&A. We will have time for questions at the end. Please complete the survey that will pop up on your screen. It will help us as we evaluate the program. Also, Lilly, BHM, and our community partners are hosting a free mammogram screening event for uninsured women ages 40 plus who have not had a mammogram in the past year. And this will be held at the Acres Homes Multi-Service Center in Houston on Saturday, May 7th from 8 a.m. to 5 p.m. To schedule an appointment, feel free to call 888-233-6121 Monday through Friday, or go register online at www.assuredimaging.com/BHM. We will share the flyer. Now, I would like to introduce you to our presenters. First, we'll have a brief presentation from Dr. Stacey Jones-Reed, the sole proprietor of Family Health and Wellness Center, which since 2001 has served Houston's Acres Homes community. She is a diplomate of the American Board of Family Medicine, and her practice is aimed at improving the health of patients, families, and underserved communities. Dr. Jones-Reed graduated with a Bachelor of Science from Howard University and a Doctorate of Medicine from McGovern Medical School at UT Health. Her residency was completed at St. Joseph's Family Practice in Houston. Next, we have Mia Williams, a strategic consultant specializing in equity, diversity, and inclusion. Ms. Williams is a longtime resident of Houston, Texas by way of Acres Homes. She's a graduate of Texas Southern University and Prairie View A&M University with degrees in criminal justice with a concentration in public affairs and an MA in counseling. She's the owner of Melanin Marketing Management and is a 15-year triple-negative breast cancer survivor. She's also a lifelong advocate for accessible, affordable, and equitable breast care. For the last 10 years, she has contributed to the breast health community through volunteerism, moderating, and facilitating support groups, and has served as a panelist at several conferences and convenings. In December 2020, Ms. Williams received a 2-year appointment by Susan G. Komen as an advocacy ambassador. Our next presenter was going to be Ms. Cynthia Johnson with For the Breast of Us, but unfortunately, she had some unforeseen circumstances arise and she could not be with us tonight. We wish her the best. Last but not least will be our key presenter, Dr. Abenaa Brewster, who is a tenured professor of clinical cancer prevention at the University of Texas MD Anderson Cancer Center and has an adjunct appointment in epidemiology. She is a medical oncologist, director of the MD Anderson Nellie B. Connolly Breast Center, and her clinical interest is the management of breast cancer. She is particularly interested in understanding how tumor genomics, post-genetic susceptibility, ethnicity, and obesity influence a woman's risk and survival after a diagnosis of breast cancer. She has experience in the conduct and data management of hospital and population-based cohort studies and is the principal investigator and director of a longitudinal cohort study of women at risk of developing breast cancer. Dr. Brewster is a Komen Scholar, an award given to individuals for their knowledge and leadership within the scientific research and advocacy communities and for their own contribution to breast cancer research. After the Q&A, we will then hear some closing comments from the presidents of the two hosting links chapters, Ms. Mary Ozen and Ms. Beryl Basham. And now let's hear from these fabulous women and community leaders that we so admire.
Hi, good evening, everyone. I'd like to start with thanking Black Health Matters and all that are involved with this important event this evening. I also need to thank my president from Links, Port City Links, and also I am a Jack and Jill associate along with Lynette. But I'd like to start by saying that when I was approached by Black Health Matters to do and help sponsor this event, I actually got very excited because I know that this is so important to our community and to just saving lives. And I was gung-ho about just participating. So I want to thank Black Health Matters for reaching out to me. I'd like to start by letting you know that I am a diplomate of the American Board of Family Medicine. I am a primary care physician in which, like Lynette has said, I've practiced for over 20 years in the Acres Homes community. Next slide, please. So my purpose this evening is to share with you the role of your family physician in actually diagnosing breast cancer and preventing, if possible, breast cancer and the management of breast cancer. Okay, Alicia, can we go to the next slide? I only see one slide. She there? Lynette?
Yes, I am here. Do you not see the prevention slide up?
I'm sorry?
I have the prevention, breast cancer risk factors and prevention slide. Is that not the slide you see?
Yes, that's it, yes. So let's talk about the role of the family physician. And it should be, we should be involved in prevention and diagnosis and also management. Under prevention, your primary care physician, and I'm hoping that everyone has a primary care physician. If not, it's very important to have one. If you could go back, there you go. Your primary care physician, when you go to see your primary care physician, you want them to discuss with you any risk factors and assess your risk factors for getting breast cancer. This graph or this chart shows you that there are some uncontrollable risk factors, and then there are some controllable risk factors. And on the bottom left corner, you'll see one of the main uncontrollable risk factors is gender. Women have a higher rate or higher risk of breast cancer. Men can get breast cancer, but women have a higher incidence or a higher risk factor for getting breast cancer. And then you will see as you go up the graph, your age, your genetic factors, early menarche or early cycles, where you started your cycle or your period before 12 is also a risk factor. Family history of any type of cancer, late menopause, after age 55, starting your menopause, or exposure to radiation. All of these are uncontrollable risk factors. But what's interesting is there are some very controllable risk factors, such as obesity or lack of exercise. Those are things that we can actually control. Eating lots of processed or fatty foods, we can control that. Using hormone replacement therapy, especially the estrogen and progesterone hormone replacement therapy. Those are associated with an increased risk of breast cancer. not breastfeeding. We know statistics show that African-American women, we don't breastfeed as much as other races do. And then giving birth at an older age, after age 35, increases your risk of developing breast cancer. And then also having no children, you'll have an increased risk. So as your primary care physician sits down and does your risk assessment, they should then move on to an annual clinical breast exam. And that's where they're actually going to physically examine both breasts. They're going to look to make sure they look the same, that there are no physical abnormalities that can be seen. And then they'll feel the breast and up in the corners of your, what we call the axilla, or the common name is underarms area. You also will expect your family physician to educate you about the importance of mammograms like we're doing this evening, and also to teach you about what a self-breast exam is and how to do a self-breast exam. This is so important because when you do a self-breast exam, you may be able to detect a lump quicker or earlier than a mammogram can. Next slide, please. So I quickly wanted to share with you all, next slide, how to do your breast self-exam. You do want to pick the same time each month. You want to look at both breasts in the mirror, and there you're going to examine just to see that one is not bigger than the other one, or there are no lumps or no visible skin dimpling or anything redness like that. You'll take your 3 middle fingers and actually go in circular motions around your breast. This area right here is where you're going to actually feel and have this area contact your breast. Then you'll look and feel for lumps, any hardened knots. And I always tell my patients, it'll feel hard. It won't feel like regular breast tissue. But the important thing is if you do this every month, you'll get used to what regular breast tissue is. And then you'll be able to say, oh, wait, that wasn't there last month. So that's one way in which you can detect and in doing your self-breast exam. And then in terms of diagnosing, your primary care physician should refer you for a screening mammogram. I need you to go back one slide, please, Alicia. And in referring, it's a slide here that just talks about your age group and who should be referred yearly and what age you should start. Typically, I start at age 40 in African-American women, screening and sending them for mammograms yearly. I try not to skip. I've noticed that I am diagnosing breast cancer earlier than age 40 in African-American women. And so we do a good assessment, but I make sure if they do have family history and increased risk factors, I really try hard to get them in maybe at age 38 or 39. And then also your primary care physician should plan a follow-up visit with you to discuss the results of the mammogram. Hopefully everything will be fine, it will be normal, and it will be an easy visit. But if it is not normal, or if it's an abnormal mammogram, usually they'll ask for additional testing or additional screening, and your family physician will help you guide you back to the facility and write the orders or the referral for that to take place, plus discuss with you what this could mean or what they're looking for. And then pending those results, your primary care physician will refer you to a specialist, like a surgeon, if there is an abnormality found. Next slide. We're almost finished, and we're trying to stay on a schedule. And then lastly, your primary care physician should help in the management of if you are diagnosed with breast cancer. They should help work with the team of oncologists, with your nurses, with your rehabilitation, and also just your additional screening once you've been treated, and let you know when you need to follow up with the oncologist, and just keep things kind of flowing and the communication going between all that were involved. And lastly, I'll just say, and I'll try to leave everyone with these 3 important points. And here's just the management or recommended surveillance: 3 to 6 months of physical exam The breast exam is monthly. The mammogram would be 1 year after the initial mammogram based on the abnormalities. And also it's important to remember to do your pelvic examinations. But I'd like to just leave a closeout for me with 3 important points. Number one, size does matter. That means the bigger the tumor, it has been found that it can be correlated to a decrease in survival. So the earlier, the second point, earlier the better. The earlier we get the mammograms and detect any abnormalities, the better. And lastly, over the years, the survival rates have increased. Whenever I have to diagnose anyone with breast cancer, it really, really helps for me to be able to say that the survival rate has increased and that science, we've done a great job at helping you live a great long life and not allowing breast cancer to be the actual story or the end of your life. So with that, I will turn it over to the next speaker. Thank you.
Hello, my name is Mia Williams, and I would like to first thank Black Health Matters and Lynette Roach for inviting me to share my experience as a breast cancer survivor and advocate. So just a little bit about myself. I am what one would consider as a young breast cancer survivor. I was diagnosed at the young age of 34. I had 3 young children at the time, ages 6, 4, and 18 months. And so when I was initially diagnosed, my husband was by my side at the time. And when I was first diagnosed, I immediately thought of, I'm going to die, and I'm going to have a little bit of comic relief here to tell you that at that time, I was like, I didn't want any other woman raising my children. I'm just trying to be honest with you here. But that's where my head was. And so I want to say that after we composed ourselves and decided, you know what, we're going to fight this, I took on this disease head on. And so when I went in for my initial, the removal of my tumor, I went into what they call anaphylactic shock on the table, which means that I had an allergic reaction to the dye that is designed to determine whether or not the cancer has spread to other areas of your body. So immediately my surgery had to stop. And at that time, a beautiful Black surgeon by the name of Jamie Elizabeth, I can't remember her last, Jamie Elizabeth Terry, I'm sorry. She did what she did to resuscitate me and bring me back to life. However, unbeknownst to me, they weren't able to finish the surgery. So I had to go back in for a second round of surgery for them to continue removing the cancerous cells. Fast forward. So as a Black woman, you know, our hair, our eyelashes, all those things are very important to us. However, at that time, I had a will to live. So I didn't care about the hair, the eyelashes, any of that. So I was able to make it through a successful course of treatment for triple negative breast cancer. And so I figured, you know what, I'm good, I'm great, I can live my life and be a healthy advocate. However, what folks fail to realize is that after one is diagnosed with breast cancer, other ailments begin to attack your body. So as a result of the breast cancer, I suffer from lymphedema, which there was an act that was a legislation that was attempted to be passed about 2 years ago to help those women who are diagnosed with lymphedema. That's that excess fluid that builds in your arms and sometimes causes a physical abnormality where you can't wear your clothing and things of that nature. Not only that, but after the radiation, because I had to have radiation on the left side because that's where I was diagnosed. I have a heart condition now because of the extent radiation. It has impacted my heart. So there's a little small pin-sized hole in one of my valves as a result of the radiation. Then there's another piece. When you have health care, it's easy for you to go and get your regular annual mammograms, right? In 2018, I was laid off from my job. And at that time, my husband and I were separated. I didn't have any medical insurance. And in order for me as a breast cancer survivor and thriver to maintain optimal health, you have to have annual mammograms. But because I was not afforded the opportunity to no longer have health insurance, it was difficult for me to get this annual mammogram. I had to go to other organizations. I had to swallow a lot of my pride to be able to get those difficult to attain resources in order for me to have my mammogram done. However, in 2020, my husband passed away. And as a result, it's unfortunate, but after he passed away and he was a veteran, I was able to once again obtain insurance. So again, breast health or breast survivorship is not just a one-stop shop, so to speak. As a survivor, we have other issues that we have to deal with, lifelong issues that we have to deal with. So if you know of a breast cancer survivor or someone who is unable to maintain that optimal health simply because they are unable to get a mammogram, I would ask that you would refer them to our event on May 7th, where they can come and get a mammogram, and they don't have to be ashamed, because in order for us as survivors and advocates to continue this work, we have to show our vulnerability and let folks know it's okay and you don't have to be ashamed. We want each and every one of us to be able to live strong and healthy lives. And if that means we have to go within ourselves and say, you know what, it's okay, I can do this just so that I can maintain my health, then by all means, I would encourage you to do so. Thank you so much for your time and your attention.
Good evening, everyone. And Mia, thank you so much for sharing your story. I wear two hats. As mentioned, I'm a breast medical oncologist, but I'm also a breast cancer prevention researcher. And so during this presentation, I'm going to give you a little bit of both aspects of what I take care of. Next slide, please. So I think we should first kind of maybe back up a little and talk about what exactly is cancer. And essentially, it's just abnormal cells. It's your own breast tissue that have become abnormal. And when these cells become abnormal, they can actually grow pretty quickly. And what happens when you have abnormal growth of cells in any part of your body is that it can form a mass. Sometimes we call it a tumor, sometimes we call it a lesion. And what we do know is that when women are able to feel this in their breast, it's probably already about 2 centimeters. Not everything that you feel in your breast that feels like a mass or feels like a tumor is necessarily cancer. There are a lot of things that are actually benign that you can feel in your breast. But when a biopsy is done and we see abnormal or malignant looking cells, as we call them, then we diagnose a patient with cancer. Next slide, please. And so a little known, or really what I would say is a misconception, is that we actually can prevent cancer. And as Dr. Stacey Jones-Reid mentioned, there are some factors or some practices that we can all do to prevent breast cancer. Next slide, please. So here are some of the tips that I'm going to share with you on how you can reduce your risk of developing breast cancer. Number 1, maintain a healthy weight. And I know that's sometimes easier said than done, but certainly maintaining a healthy weight is a very important method in which we can decrease the chances of getting not just breast cancer, but other types of breast cancers, for example, endometrial cancer. Next slide, please. Get active. And I always tell my patients that exercise isn't so great for helping you lose weight because you actually have to do a lot of exercise to be able to lose weight, and you have to sustain it over a long period of time. But exercise is fantastic even if you don't lose a pound. And the reason why is that exercise decreases the inflammation that we have in our bodies. It regulates your hormones, it relieves stress, and more importantly, it prevents weight gain. And so continue to exercise, don't look at the scale, and the exercise that we recommend is about 150 minutes per week. Can you just keep advancing, Alicia? Another little known risk factor for breast cancer is limiting alcohol. We usually recommend that women don't drink any more than 1 beverage per day. Next bullet, please. And then choosing to breastfeed. Breastfeeding is wonderful in terms of the baby's health, but it's actually a huge benefit to mom. And when we talk about breastfeeding, we talk about women who are breastfeeding for more than 6 months. Continuous breastfeeding for more than 6 months is associated with a decreased risk of developing breast cancer. And know your family history, because if you identify that you have family members with either breast or ovarian cancer, those are factors that you'd want to share with your primary care physician in terms of better understanding whether or not you have a hereditary breast cancer syndrome in your family. Next slide, please. And so as Dr. Jones-Reid said, there are a lot of risk factors that you can control, and we'll just go through them one by one. Next slide. Continue, Tisha, good. And so I wanted to spend a few minutes talking about dense breast tissue because this is something that women hear a lot. It's also noted on your mammogram. And we know that women who have dense breast tissue, which is actually a lot of women, but we know that dense breast tissue in some women is associated with a higher risk of developing breast cancer. And we don't really understand why that is, but dense breast tissue is something that you should pay attention to. And of course, as we mentioned, genetics. We really can't control our genetics, but understanding what our family histories are, understanding some of the red flags for having a family history of breast cancer can at least help you then take that information to your primary care doctor, who might then refer you to a genetics practice in order to identify whether or not you're truly at a high genetic risk of developing breast cancer. Next slide, please. So here are some of the red flags for hereditary breast cancer. So if you have a family that has a lot of young women with breast cancer, that's something that you want to let your primary care doctor know. If you've got many relatives on the same side of the family with either breast or ovarian cancer, that's a red flag. If anybody in your family has been diagnosed with both breast and ovarian cancer, automatically a red flag. If any of one in your family has been diagnosed with bilateral breast cancer, that means breast cancer in both breasts, red flag. Likewise, anyone in the family with a triple negative breast cancer, or if you yourself have had a triple negative breast cancer, that's a red flag that you may have a hereditary breast cancer syndrome in your family. And certainly, any woman who has any male relative who has breast cancer is a red flag for hereditary breast cancers. Now, a lot of times patients say, but I don't have a family history of breast cancer. And I say, yeah, we make a big deal about these hereditary breast cancers, but in fact, they account for only about 10 to 15% of breast cancers. So the majority of breast cancers that occur in women who do not have any of these red flags in their family, or may not even have a family member who has breast cancer. So just remember that you don't need to have a family history of breast cancer in order to be at risk for developing breast cancer. Next slide, please. So I think Mia said it best. You are your best advocate. And this is for every sense of the healthcare system, whether or not you're interacting with a primary care physician or whether or not you're interacting with an oncology team. Next slide, please. And because you are your best advocate, there's no one that knows you as well as you know yourself, and that includes your breast. Next slide, please. And so I just wanted to go through in a little bit more detail what exactly you're looking for when you perform a breast exam. So first of all, you're looking to feel whether or not there's anything hard or firm in the breast. I actually see a lot of patients in the Cancer Prevention Center at MD Anderson who say, I don't know what I'm feeling, and I'm scared to examine my breast, and I don't know what I'm feeling. And I always share that in my oncology practice, I don't think there's any breast cancer patient that I've ever met who has felt a lump in her breast who didn't think that something was definitely not right. And that's because lumps in the breast that are generally, that may be cancer, tend to just feel abnormal. They feel like they do not belong in your breast. It's hard, it's firm. Don't be scared to examine your breasts, because when you feel an abnormality, it's going to be pretty clear. As Dr. Jones-Reid said, you also want to feel under your arm to see whether or not there are any lumps or bumps. You also want to pay attention to if there are any skin changes. We talk a lot about redness of the breast, but for women who have a darker skin complexion, they may not see redness of the breast. And instead, the skin changes of the breast may actually be a deepening or a darkening of the skin. Likewise, if you see any dimpling or puckering in the skin of the breast, it probably means that there could be a tumor in there that's pulling on the skin of the breast, and that's a red flag. Likewise, if you notice your breast developing kind of what looks like an orange peel, it means that there's swelling of the breast, and swelling of the breast in that manner is abnormal. And likewise, if you notice any change in the size of your breast, those are all signs that you should be seeking attention from a physician. Next slide, please. And so the nipples are all part of your breast, and they're all included in that exam. And so some of the nipple changes to look for is whether or not you notice any bloody discharge. Now, women who have just finished lactating or who have lactated over the past few years can have a clear milky discharge from their nipple, and that's usually not an issue. It's when you notice a deep brown or bloody discharge that you should bring to the attention of your physician. Likewise, if your nipples have never been inverted and all of a sudden a nipple is inverted, that is something that's a concern. If you notice any crusting or ulceration of the nipple, or any change in the direction of the nipple, meaning it seems as though something is pulling the nipple in a different direction, those may all be signs that there's something growing in the breast that's abnormal that needs attention. Next slide, please. And then lastly, get screened. And these are the recommendations for screening. So if you're between the ages of 25 to 39, you should definitely be getting a clinical breast exam at least every 1 to 3 years. And the recommendation for when you should start getting your annual mammograms is age 40 and older. So starting at age 40, that's when you should be tugging at Dr. Jones-Reid and reminding her to schedule that screening mammogram, and of course, performing a clinical breast exam. I just wanted to mention a little bit about that breast exam. So your doctor is going to do a breast exam, and it's going to be the perfect breast exam. We're going to do it in exactly a very specific way. We're going to check under your arms, we're going to squeeze the nipple, and we're going to perform what we call a clinical breast exam. But the breast exam that you perform at home, right now, we just say feel your breast. You don't have to perform it in any specific way. You don't even have to perform it any specific time of the month. The recommendation is that women should just get to know their breast. So whether or not you're in the shower, whether you're lying on the couch in the family room watching television, or in your bed, just feel your breast. And that's all we're asking, and try to do it regularly. Next slide, please. And so these are the options for women who are deemed to be at increased risk of developing breast cancer. And this is information that your primary care doctor might share with you after you've told them about some of your risk factors, after you may have shared your family history. Then these are some of the different strategies that your primary care physician might advise you to take. Number one, they may say, you know what, you should get started testing or getting screened at an earlier age. And so for women who we think have a higher risk of developing breast cancer, we don't want to wait until age 40. And in fact, we might start screening as early as age 35. Also, we add a MRI of the breast or we add an ultrasound. And so for women who are at high risk, we usually recommend that they have an MRI of the breast in addition to the mammogram that's being performed. And we alternate this every 6 months. Believe it or not, there are actually medications that are recommended to prevent breast cancer. We reserve these medications for our high-risk women, and they're usually medications that you can take over a period of about 5 years, and they reduce your risk of developing breast cancer by about 50%. As I mentioned, genetic testing, family practitioners like Dr. Jones-Reid will refer you to a genetics clinic if she's really concerned about that you may have a hereditary breast cancer syndrome in the family. And last but not least, for women who do have a hereditary breast cancer syndrome, some may even elect to have their breast removed with reconstruction in order to prevent breast cancer. Next slide, please. And so these are some of the resources for mammograms. So in addition to this wonderful opportunity that Black Health Matters has provided in terms of free mammograms, there are also other resources that you can access that offer mammograms to women who are either uninsured or underinsured. Next slide, please. And of course, I always remind everyone that MD Anderson is not only a cancer center, but it also does prevention. And so we have a robust cancer prevention center and offers screening mammograms to women at 4 locations. Next slide, please. And so the question is, why does this matter? Why are we here today? Why are we all taking time off from our busy schedules to have this conversation about breast cancer, about screening, about prevention? Well, the reason why it matters is that Black women are not at a lower risk of developing breast cancer than white women. We may see, I'll be honest with you, we may see the photos of white women and breast cancer. We may see photos of white women on the screening boards, and we make that association that, oh, this is a white woman's issue. It's not. Black women are at risk for developing breast cancer at the same rates as white women. The difference, however, and the reason why this is so important to have this conversation with you this evening, is that death from breast cancer is 40% higher for Black women than it is for white women for a number of reasons. And Black women are more likely to get a more aggressive type of breast cancer called a triple negative breast cancer, which Mia spoke and shared with you that she was diagnosed with. But also Mia, with her presence here today, also shows that even with a diagnosis of an aggressive breast cancer, survival rates are still very high. Next slide, please. And so what we know, and really why we're all just emphasizing that you be advocated for your care, is that we know that Black women experience or have a different experience of breast cancer than white women. Black women tend to experience longer wait times between the time that they feel symptoms to the time that they get a diagnosis. And even after a diagnosis, Black women can wait significantly longer to initiate treatment, whether or not that's chemotherapy or whether or not that's surgery. And the reason why this is so important is that we know that delays impact survival. So if you feel symptoms or if you have a diagnosis, just imagine you're on the clock. And so allowing your medical team or your oncology team to plan your surgery, plan your treatment, that is all appropriate care. But if there are other factors that are delaying your initiation of either getting to a diagnosis or getting to treatment, that's something that you need to intervene with and be your own advocate to resolve those delays. Next slide, please. The good news is that there are 3 million breast cancer survivors in the United States. And if you're a breast cancer survivor, yay, congratulations, Mia. There are 3 million of you thriving after a diagnosis of breast cancer. Even as a survivor, get your annual physical examinations. Continue your contact with your primary care physician. Your primary care physician is going to remember to do everything that the oncologist is not going to do. They're going to remember that you still need cholesterol screening, that you still need to have your blood pressure managed, your diabetes managed. So you definitely want to maintain that relationship with your primary care physician. Follow your oncologist guidance about cancer screening. Getting that mammogram and continuing to be screened even after a diagnosis of breast cancer is very important. Your oncologist is there to help manage side effects. And there are also tips to reduce your cancer recurrence risk, which are certainly within your control. Next slide, please. So I just want to share with you the survival among Black women after diagnosis of breast cancer. And this is data showing where are women at 5 years, right? Because the question is, okay, I'm scared, I've been diagnosed, but this data is not scary data. And so we know that women who are diagnosed at an early stage, stage 1, 96% of them are alive and well at 5 years. For women who are diagnosed with a stage 2 or 3 breast cancer, 80% are alive and well. And for those who are diagnosed with a stage 4 breast cancer, 26% are alive and well. And so this just shows the impact of early detection on survival. And so if you feel something, get help, because in fact, your chances of surviving and living with this diagnosis or after this diagnosis is significantly higher than if you wait and the cancer spreads further and you end up coming in with a diagnosis of a stage 4 breast cancer. Next slide, please. And so just wanted to kind of review some of the treatments for breast cancer. For those of you who are survivors, you know surgery and radiation are important components. And then we use chemotherapy and anti-estrogen pills in some women, not all. And then they're all novel new treatments that have been developed for breast cancer that have led to those amazing survival rates. For example, targeted therapies and more recently immunotherapy, specifically for women with certain types of breast cancers. Next slide, please. So these are some of the tips to reduce recurrence. If you're a breast cancer survivor, once again, it's the basics: maintaining a healthy weight, getting regular exercise, watching your diet, limiting red meats, alcohol, sugary beverages, and really staying away from unhealthy practices, for example, smoking. Next slide, please. And so, as Mia shared so well with you, acknowledge your fears. This is not easy for anyone. And even in my role as an oncologist, it never becomes easy. Meeting a woman who has been diagnosed with breast cancer is emotional. There are a lot of fears, but remember to use your imagination in a positive way. Instead of thinking about the worst case scenarios, think about the best case scenarios. And a 95% survival rate at 5 years with an early diagnosis is certainly a positive way of thinking about breast cancer. Talk with friends and family members who may have gone through this experience before, lean on them for support, and share with your healthcare providers your fears so that they can acknowledge them, resolve some of the misconceptions that you may have, and really be able to support you in the way that you need. Next slide, please. And lastly, speak up, speak up, speak up, speak up, speak up. The squeaky wheel gets the attention. So, primary care physician, you've never had a mammogram? Ask them, is it time for a mammogram? Am I due for a mammogram? Do you need my family history of cancer? Will you let me know if I'm at high risk of developing breast cancer? If I'm at high risk, will you refer me to high risk clinic? Should I get genetic testing? Is there more imaging should I do? Should I just get a mammogram or should I get an ultrasound and an MRI? And this is why we're holding this session. It was that we want you to have this information and speak up, ask these questions. Don't be afraid to follow up with your provider for diagnostic workups that might be needed or treatment that might be recommended. Ask questions if you don't understand something. If you're in a doctor's office and you don't understand what they're saying, just say, I'm so sorry, I don't understand what you've just told me. Can you explain to me in a different way that I can understand? There is nothing wrong with actually stopping a physician and actually just sharing that. And express any cultural or religious beliefs that you may have when discussing your risk, mammograms, and treatments, so we can make sure that we incorporate your values into our treatment plan. Next slide, please. And I'm happy to take any questions. Thank you.
Yes, Dr. Brewster, this is Lynette. I'm seeing some questions in both the chat and the Q&A. First of all, someone is asking, is hysterectomy a risk factor for breast cancer?
Not at all. Has nothing to do with risk for breast cancer.
Okay. Also, how much weight is too much? I'm 5'9" and 175 and have been told I'm overweight by my doctor.
So your doctor is correct. And you can look up and Google body mass index calculator. And essentially, if you put in your height and if you put in your weight, based on your body mass index, you'll see a nice graph that tells you whether or not you're normal weight, whether or not you're overweight, or whether or not you're obese. And you know, it's so normalized now that we actually, I think as women, have a hard time even knowing where we fall. And so I would say you can use that, you can put in your risk. And if you're in the overweight or obese category, then you know, okay, this puts me at risk. And it's not just breast cancer. We're just talking about breast cancer today, but it might put you at risk for some other health conditions. And so that's when you might want to reach out, talk to your doctor about it, get help in terms of programs, exercise, diet, nutritionists, so that you can have a better understanding of how to be able to manage some of those risk factors.
Very good. Next question. How does breastfeeding reduce your risk?
Great question. What we actually think that happens that when you breastfeed is that your breasts actually mature. And in fact, the data shows that women's breasts don't actually fully mature until they've actually lactated. And so when I say breastfeed, I don't mean that you actually have to breastfeed. There's some women who pump, who use breast milk and feed their babies in a bottle, but it's just the breast producing the milk that actually matures the breast tissue. And mature breast tissue is less likely to develop abnormal cells. And that's the simplest way that I can explain it.
Okay, here's another one. My grandmother had pancreatic cancer, but her autopsy revealed tumors on both ovaries, Krukenberg's tumors. Would that be considered ovarian cancer, hence increasing my risk?
It's a great question. Cancers spread. And so cancers from other parts of the organ, other parts of your body can spread to your ovaries. And it doesn't mean that grandma had ovarian cancer. And so it's possible that she had pancreatic cancer that then attached itself to the ovaries, in which case then you're not at risk because your grandmother did not have a cancer that started in her ovaries.
Okay, thank you for that. Is it possible to get a diagnosis the same day as the mammogram? The waiting period is so stressful.
I know, it's so stressful, isn't it? It's stressful even for me. And actually now with the CARES Act, as soon as the radiologist reads your mammogram, they automatically release it to you. And so if your healthcare system has an electronic medical record, a MyChart or something that they communicate with you electronically, sign up for it, because the radiologist will not only release the mammogram report to you electronically, in which case you'll get it in a matter of seconds after she signs off on it. But if you wait until you have to get it in the mail, then that's going to take a couple of weeks, and that could be really nerve-wracking. So in terms of a diagnosis, a radiologist might look at a mammogram and say, this looks really abnormal. I'm concerned about cancer. But it's usually the biopsy, which is where a needle is placed in an area that looks abnormal and then is looked at by the pathologist under the microscope that confirms the diagnosis of cancer. So we tend to wait until that's done in order to be able to tell a patient whether or not whatever is in her breast was cancer or whether or not it was benign.
All right, thank you. The next question. Can you talk about DCIS? When you are diagnosed with this, why do some have radiation and hormone treatment if they do a DMX?
Maybe if they have DCIS, did you mean? I'm not sure what DMX is. So I can talk a little bit about DCIS. So DCIS stands for ductal cancer in situ. And that essentially means that they're cancer cells, but they're still trapped in the milk ducts. And the milk ducts are what bring milk to the nipple. And so when cancers are still within the milk duct, it means that they haven't invaded into the breast, They don't have a risk of spreading to the armpit or spreading in any other part of your body. It really is truly a localized cancer. And we actually call it a stage 0 breast cancer. The reason why when we diagnose DCIS, we recommend that patients have surgery and radiation is because we don't know which DCISs are going to stay in the breast and never break through the milk duct and get into the breast tissue, and it'd be at risk of spreading or essentially become an invasive cancer. And so because we don't know which DCISs are going to stay DCIS and which are going to progress and become an invasive breast cancer, then right now what we do is just say, okay, let's just remove the DCIS so we don't put the patient at risk in the future of developing an invasive breast cancer. But we think that that's probably going to change over time because there are a lot of studies that are looking at whether and following patients with DCIS who have not received surgery and radiation and are just essentially following them to see how they do.
All right, next question is, what is the age to encourage our daughters to start baseline mammograms?
So right now, the age for an average risk woman is at age 40. Now, if your family has I mentioned all of the red flags. So if you see those red flags in your family, well, that's when it's time to have a conversation with your primary care physician so that they can determine whether or not you're at regular risk or whether or not you're at high risk. And if you are at high risk, then the recommendations to start screening are actually at around age 35.
Thank you. Please discuss the oncotype test for breast cancer.
It's a great question. And that sounds like someone who is a breast cancer survivor. And so the Oncotype DX test is a wonderful test that we now use routinely in the clinic. So when I started training in breast cancer, and even when I started my position at MD Anderson in 2002, essentially if a woman had a breast cancer that was greater than a centimeter, we said, looks like we're going to have to do surgery, maybe radiation, but definitely chemotherapy. And that was because we didn't know which of those tumors were bad actors and which were actually quite favorable. And so now we're able to send a little bit of that tumor to get what we call the Oncotype DX test, which is essentially a test where they look at the genes within a specific patient's tumor. And based on those genes alone, we're able to determine whether or not this is in fact a cancer that needs chemotherapy, meaning that it's fast growing. There's a chance that it may have spread to other parts of the body. So we want to treat a patient with chemotherapy to kill any cells that may have gotten away. Or based on those genes, we might decide that, you know what, this is a really favorable cancer, and the chances of this cancer having had spread is very small, therefore chemotherapy is not needed. And so the Oncotype DX test is really used to determine who needs chemotherapy and who doesn't. It's been a wonderful test because I can tell you, we treat a whole lot less women with chemotherapy than we did even 10 years ago.
Okay, I think we have time for just one more question. The age you no longer have to have mammograms.
Another great question. This comes up all the time. So the screening studies that were done, which showed that mammograms reduced the risk of a woman dying of breast cancer by about 25%, only enrolled women who were up to age 70. And so we actually don't have real good data on whether or not mammograms are of benefit for women over age 70. But it doesn't make sense that they won't be, right? And so we continue screening even after age 70. But the time that we really make a decision with a patient and say, you know what, we should really stop screening you is when we don't think that she has a life expectancy of more than 10 years. Because there's no point if I'm seeing maybe an 85-year-old and I don't think that she is going to live to 95 to continue screening her for breast cancer. So that doesn't mean that I'm not going to still perform a breast exam and just make sure there's nothing obvious or any problems with the breast. but she doesn't at that point in time need a screening mammogram. So we stop when we don't think the life expectancy of a patient is more than 10 years. And certainly if we think that there are so many other medical problems that taking her to surgery, if we did find a breast cancer, would put her at significant risk.
Dr. Brewster, I'm afraid that we don't have time for a few more questions. Right now, there are about 3 or 4 more that I am seeing. Would it be possible for them to direct the questions directly to your email address? Would you mind answering those?
I'm happy to, if I can do the questions, put them into chat, if that's okay. I guess I think there are a few folks who are still needing to speak, so I'm happy to address some of the questions I may have missed in the chat.
Okay, we can do that.
Okay, thank you.
And now we're going to have some remarks by the representatives, the presidents of the 2 Links chapters. First will be Mary Ozen with the Port City chapter of the Links, and then Beryl Bashan with the Texas Springs Cypress chapter of the Links.
Good evening, everyone. My name is Mary Ozen, and I serve as the president of the Port City chapter of the Links Incorporated. The Links Incorporated is one of the nation's oldest and largest volunteer service organizations of women who are committed to enriching, sustaining, and ensuring the culture and economic survival of African Americans and other persons of African ancestry. First, I would like to thank the members of the Black Health Matters organization for inviting us to partner with them in this very worthwhile project, promoting the prevention of breast cancer in communities of color. And now I would like to share with you a snapshot of some of the services that we have provided over the years. We are friends first, and we work together, transforming communities through service. The members of the Port City chapter have served the Houston, Texas community for 35 years in underserved communities, including the Acres Homes, Sunnyside, and the 3rd Ward. Our programs include the DASH Diet program with our long-standing partnership with Dr. Stacey Jones-Reed, one of the panelists tonight, and her medical practice in the Acres Home area. This program provides monthly sessions to learn about the benefits of healthy eating, as well as learning healthy shopping and cooking strategies to address high blood pressure and diabetes, which is prevalent in communities of color. We have also sponsored the Mind Your Health mental health fair for the residents of the Acres Homes area. We have also served the Sunnyside and 3rd Ward communities in partnership with our corporate and community partners by sponsoring our annual Health, Education, and Science Fair and Carnival at Sunnyside Park for the past 14 years. The fair highlights STEM careers, health education, and awareness for hundreds of students and their families. Other programs include sponsoring National Society of Black Engineers junior clubs at Houston ISD and Fort Bend ISD schools, Read Aloud program via our YouTube channel, promoting STEM and STEAM education, Dashing Seniors program in partnership with the Houston Methodist Hospital and the Houston Texans YMCA, providing health-related programs and activities. And our newest program, Education Across the Miles in Ghana, Africa, in partnership with Literacy for Life Foundation to build a library and in the future provide books and virtual literacy programs for the students. In closing, I would like to thank each of you who chose to join us tonight for this very important message. Breast cancer prevention saves lives. Thank you.
Hello, I'm Burl Basham, and I'm president of the Texas Springs Cypress chapter of the Links Incorporated. I want to say that after listening to tonight's program, I'm even more grateful than I thought I was when I came on, and mostly because the testimonial from Mia and hearing Dr. Stacey Jones and Dr. Brewster was very informative. And I thank you all for taking the time to speak with us tonight. I also want to thank Black Health Matters. Black Health Matters pulled together a collaboration between the Port City chapter and the Texas Springs Cypress chapter, and we're deeply grateful for that. I'm particularly grateful because I am a breast cancer survivor myself. And listening tonight, although I speak often about being a breast cancer survivor, and I've gone to a number of different sessions, each one is even more informative. So I'll say that you all have shared information that I might not have even known otherwise. So I also want to talk a little bit about the Texas Springs Cypress chapter and what we do in the community. Not only have we partnered with Black Health Matters, but we partner with other community organizations such as St. Monica Catholic Church, the St. Monica Food Pantry. We work with the Lincoln Park Community Center, HISD, and numerous other organizations to provide financial support and hands-on volunteering for areas such as food insecurity, helping with rent stabilization, scholarships to go to school in the community, improvement of technology. And most recently, actually, we did a program that we most recently completed in working with students in the arts for a poster art program, which is a national program. I really would like to just say again, thank you for coming this evening. And I'd like you all just to remember to put yourself first. Go for your annual mammogram. Put it in your calendar. Maybe even make it fun. Invite your mother, your friends, your sister, and others to join with you in going to your annual mammogram. It'll help you remember. And last but not least, if you haven't registered already and you are over 40 and uninsured, please join us on May 7th from 8 to 5. Thank you very much for coming this evening.
Thank you so much, Vero. I'd like everyone that's attending tonight to please fill out the survey that will be starting soon. We really need your feedback. It should be on your screen and there are only a few questions. Okay, in closing, We'd like to thank Dr. Brewster, Dr. Jones-Reed, and all of our community partners for co-hosting this event tonight with Black Health Matters and Eli Lilly and Company. And if you'd like to see our next big virtual event, go to www.bhmsummits.com to register for the BHM Spring Health Summit on this Saturday, April 30th from 9 a.m. to 5 p.m. It's our first hybrid one, live from Harlem, New York, and it will also be streamed online. Thank you so much for joining us and have a great rest of your evening.